So the request I got from the division was really around these 6 questions, and I've tried in the presentation to address them tonight. So really I'm going to take you through our experience in Alberta in primary care reform since 2003 to the present. So in 2003, Alberta Health and Wellness, which is now Alberta Health, and the Alberta Medical Association, so that's like Doctors of BC, and Alberta's regional health authorities, so that's when we still had a decentralized model. It is now Alberta Health Services, one model. Anyway, they all got together and they formed what was called the Primary Care Initiative. And part of that was to create these things called primary care networks. And essentially, these are non-for-profit joint venture agreements between a group of local, geographically organized family physicians, and they form the JV joint venture with the local health authority. And then the funding for that comes from the government, Alberta Health. And then when we started this off, it was calculated at a per capita basis of $50 per patient, and that went up to $62 probably 3 or 4 years ago. And the first 5 PCNs, including mine, went live in 2005. So really, we've been, on this this track now for basically 10 years. So there were a number of goals established. The first was to increase the number of Albertans with ready access to primary care, manage the access to appropriate round-the-clock primary care services, increase the emphasis on health promotion, disease and injury prevention, and care of patients with complex problems or chronic disease. There was also a goal of improving the coordination, so basically talking about vertical and horizontal integration, and facilitate the greater use of multidisciplinary teams in the care of patients. Governance models, basically the broad brushstroke differences here are in one model, the funding flows directly to the physicians as part of that JV, and the physicians really look after the day-to-day running of the primary care network. The joint venture partner is really there to sign off on the business plan and to also okay certain line items in excess of $100,000. So really what that model does, it gives the physicians more control, more power if you like, but it also gives them more risk. In the other model, the funding comes to both entities, and both entities do what I just mentioned about the other model. So again, a little less control, less power, but also less risk. It really, in my opinion, does not matter what that looks like, because like any good relationship, if it works, it works, and it doesn't matter what it says on paper. But I guess kind of like a prenup, once things don't work out, you need the paper bit to back you up to figure out the lay of the land forward. So in Alberta, we have 42 PCNs. We have 3,300 family docs as members. We employ 1,100 other health professionals. That would not include admin professionals. We serve 3.2 million Albertans, and the budget is a whopping $163 million and some cents. So let's talk about the successes. So when we started the emphasis was very much on local solutions for local needs, using those goals that I went over, which did give a high degree of flexibility to PCNs to promote those things that they thought was important. It was also a really important hook to get people interested, because they were not interested in anything coming from up high. They wanted to be, grassroots and up. So a lot of the PCNs focus their resources on developing new clinical care programs and teams. And these would take on basically two forms, either a centralized team or a decentralized team. So centralized would obviously be a co-located team in your office. Decentralized, it's something that you can refer people into. So there was some analysis done of the performance of primary care networks by the Health Quality Council of Alberta. And as you can see here, it shows that as a result of the goal to increase access to primary care provider and team, that patients belonging to a PCN who are healthy and have minor conditions are requiring less hospitalizations. It further shows us that when the patients have a high degree of attachment, so they really see their own provider mostly, that they have a significantly greater decrease in hospitalizations. What this also shows is that patients with severe chronic conditions increased, but the increase was less, again, if they were highly attached. Looking at MyPCN's data specifically, it shows that although the number of visits to the family docs went up post-PCN introduction, might be appropriate that happened because they have better access. But you can see there that the ER visits declined significantly, and the admissions as well. So multiple areas of improvement. So what were the challenges? There was this myth that took hold that somehow this funding was really there to provide family docs the income that they deserved for all the work that they did that they weren't paid for. So, for a lot of people, this was piggies at the trough time. And, handing out money and, a lot of non-activity based stuff going on. And so really it was seen as an income supplement, which, it really wasn't meant to be. And although there were those guidelines, they were never really enforced and they weren't actually all that clear. Also put together a group of docs and staff and allied health professionals in a room, and people come up with fantastic ideas. But you can't have too many toys in the sandbox. And if you have too many ideas and too much funding going to those programs, you dilute the field essentially. And then you often get plans that are not well thought out. And these would be things that, again, not a value judgment, but let's hand out 1,000 pedometers, or let's hand out certificates so people can go swimming. And there's some good evidence that shows some of those things work, but is it really the things that we ought to be focusing on in the big picture? This is the thing that really, is killing us and almost did. And although the goals were helpful, there were no measures attached to it, and no consequences for not measuring or achieving the goals. And so again, we took on these goals, but we didn't have good structure around it. And we also had we were navel gazing. We didn't think beyond our own PCN. Other than in a very informal way, learning from, across PCNs, there was no formal way of actually learning from others and not repeating the same mistakes. But also, we didn't focus on system-level achievement measures and outcomes. We didn't somehow tie together what all these groups are supposed to be doing in what is the direction for the province as a whole. So really, we were a little bit like teenagers. We were pushing the boundaries, and we were testing our parents to see how much they would take. So, governance. Oh my goodness, the purgatory. It's a word that people's eyes glaze over, etc. And again, it is really key and crucial that you get this, that you are trained in it, and that you adhere to it, because if you don't, things can get messy. So figure this out. None of us have, well, some of us don't have business skills. And so again, what were they thinking? Handing a $20 million budget to a redneck Yahoo like myself and say, go play. So we realized, we were not probably getting the value, return on investment that we were looking for. So in 2013, the then health minister said, okay guys, let's look at the next wave of these PCNs and let's evolve them. We were given this task. It took us a year to produce the document. It was actually a remarkable effort over a year's time that involved multiple stakeholders and ended up with a really robust document at the end of the day. And so what we're doing is we're trying to learn from the mistakes we made before and move it to the next level. And a big part of that is cultural change. And cultural change is hard. You always have your early adopters. But ultimately, remember that this is the goal, to get everybody to that side. But it's a long-term goal. You can't be impatient about it. So PCN evolution is really structured. Our mantra is the patient-centric medical home. So again, for the few that are not familiar with this, in Canada, the PCMH is advocated by the College of Physicians no, this is wrong. But anyway, so the College of Family Physicians of Canada advocate this is the model to use for the future of primary care. And there are 10 pillars associated with this structure. Again, I'll just go over them briefly. Care in the home should be patient-centric. There should be a personal family physician available to the patient. It needs to be within a team. Timely access for that care. It needs to be comprehensive. It needs to be continuous. And it should be supported by things like the use of electronic medical records and health information. Education and training needs to be part of that, not just your own, but also bringing in learners. And then there needs to be system supports and evaluation attached to that. So, good to read up on that at some stage when you have a minute. So that's one thing to know, that this is what you want it to look like, but how are you going to get there? And so we have landed on the implementation elements that we think are necessary for the medical home. And this, we found this in this Safety Net Medical Home Initiative, which was a 5-year demonstration project that ended in 2013. And what they did is they helped 65 primary care safety net sites to become highly functional patient-centered medical homes and achieve benchmark levels of quality, efficiency, and patient experience. The goal of this initiative was to develop and demonstrate a replicable and sustainable implementation model for medical home transformation. So, like a real home, there needs to be some preparation before you start. And so the system supports, which is what is circled there, are really important, such as integrated information systems, workforce development. And also each PCN would provide support, specifically clinical support, such as EMR IT supports, evaluation, governance, and business planning, quality supports like access to improvement facilitators, developing physician champions, and improvement tools and resources. Currently, we are working on these foundational elements: engaged leadership, capacity for improvement, panel, and continuity. So again, it's not rocket science. It's just math, fractions, and not what we do in Alberta. So it is really about who are your patients, who are the people that you are looking after. Now, most doctors say, I know who my patients are, and then you say, okay, so how do you know that? And then if you're still on paper, you'd say because there are so many folders there. If you're on EMR, you'll say, I can pull up my list and that's how many there are. But, again, that's not really very scientific. Where's the process? Where are have you gone through this list? Looking at the people that have died and taken them off the list, the people that have moved to other locales, the people are now seeing a different physician, or the people that actually see more than one provider. And if you look at the reviews, that could be as high as 15 to 20% of your patients might be seeing more than one family doc for the same stuff. So again, once you start measuring stuff, it's kind of interesting to see what you might find. Is there an aha moment there, please? Anyway, I tried to rotate this slide, but I couldn't manage. So anyway, but you're all bright people, you get it. We had set this priority goal for ourselves as our first out of the gates to do one when we produced the PCN evolution document, and that is that we wanted to have 80% of physicians with panel identification processes in place. So this was the end of December last year. So this was collected from all 42 PCNs, and it basically just shows the levels of panel, the panel progress made to date. And essentially, to just make that clear for you, it shows that over 50% of practices in Alberta are currently either paneled or actively working and maintaining and implementing panel identification and maintenance as processes. And then a further 20% are actually interested, and the rest, we'll see. And this is often dependent on the size of the PCN, the capacity to support some of these things, and so on and so forth. And so again, so why you'd say, okay, so you told us about panel, who cares? If it's an accurate list. Well, again, going back to the fractions, if you have a numerator and a denominator, you can then start doing what we call panel management. You can start looking at what is your access and why does your access suck. You can start looking at who are your diabetic patients, and then once you know who those are, then you can start looking at, okay, so how many of them am I getting to target A1Cs, if that's what you choose. You can also start looking at what are the needs of the patient populations that's in your charge and in your care. And if you know what their needs are, you can actually make some informed decisions about what should the team look like that is supporting you in that quest. So there is a big journey for all of us, regardless of what models you choose and how you're going to measure this. And this is the culture shift of becoming a new kind of doctor, moving from autonomy to accountability. And I'm sure this scares a lot of people. So the classical features of autonomous professionalism is altruism, a quest for excellence, managing poorly performing physicians, and rationing public health care resources. So despite what was drilled into us when we came out of the womb, this is not a divinely ordained right. Actually, there's a reason why this is how we've practiced all along, and that is something that was culturally given to us by our patients, the public. It's legally and structurally granted to us by the state, and it's based on trust, respect, and deference as substitutes for accountability. So autonomy, accountability, which way, do we go? So the problem with the social contract of professional autonomy is that both the profession as a whole and individual practitioners assumes autonomy for itself, and the latter limits the former. Individual autonomy with minimal accountability has caused the crisis in professionalism, or what we often deem to be the crisis of usurped proletarianization of our profession. So core attributes again of professionalism, accountability. Autonomy is really a substitute or a delegated form of accountability. And why did this happen? Because we couldn't measure before. In the world before apps and internet, whatever, there was no real way that we could actually assess performance. So let's talk about accountability then. There are a few elements of that: control, responsibility, answerability, and responsiveness. Using this definition, one might say that the traditional professionalism would be one of having control and then deciding how responsible, answerable, or responsive you want it to be. A new professionalism will make clinicians more answerable, more responsible, and more responsive. However, the crucial part of control is where the cookie might crumble, because we cannot be held responsible for what we can't control. So that would be things like adequate support for what we do, budgets, personnel, equipment. Again, we cannot be responsible for what's without our control. There's increased utilization through immigration, aging, new technology, and then one of the the single greatest cause for worsening health conditions is socioeconomic inequality within countries and between countries. Not something you and I have any control over. So this is all scary, but instead of putting our heads in the sands, running away and taking an Ativan, why wait until the inevitable is going to be handed to you and this is just how you have to do it? Why don't we lead and take charge of that process so that we actually have a say in what it might look like? So in Alberta, as shareholders in Alberta Inc., physician experts are developing clinical protocols, care pathways, and evidence-based guidelines, while physician leaders oversee the clinical governance and practice management in PCNs. We are being aided by building bridges to our communities involving the public. And again, you probably see this here too. This is a public who is demonstrating increasing levels of civic literacy and engagement. While an emphasis on evidence, we are learning that more delegation, substitution, and team-based services provides better care at lower cost. That was meant to be with. So if we cling to traditional professionalism, we may feel threatened and we again may feel isolated. We may yearn for the time where we were talking about the art that is medicine and that is being replaced by guidelines and practices and by rote feeling like you're working in a factory. Of course, we know that there are many gray areas that exist where evidence-based quality isn't clearly defined and where subtle judgment based on your skills, good training, and experience would be vital. The patient-physician relationship will always remain central and pivotal in this whole experience and part of our profession. So really, PCN evolution, or whatever evolution you want to call it, is really a righteous revolution which is being led by primary care and will have far-reaching effects on our entire profession as it galvanizes system transformation. We should not rest until we have infected, converted, and transformed the system with the core tenet of patient-centric practice. If we embrace new professionalism, we will be liberated. It is time for us to burn the bra that is old professionalism. So, our PCN. We look after 320,000 patients. We have 430 physician members. Now, annual budget is $20 million. This is the team that I work with. This does not include my core office team, which would be the LPN, the receptionist, and the admin assistant. These are individuals that are sourced and supported to us by our PCN. So we have Bethan starting closest to me here. She is a geriatric nurse consultant who does in-office assessments but also can go and do home assessments for us. We then have Lauren, who is our physiotherapist, Natasha, who is a chronic disease management nurse, and then we have Jordanka, who is the behavioral health consultant, which is basically a psychologist. Doesn't have to be a psychologist, but typically they are. And then the star of the office is Lizzie, who really has been pivotal in us figuring out a whole new way to support physicians. So she's really working as our panel manager. She's also a POET, which is an acronym for prospective office encounter technician. So these are people that look at your day, look at the patients, and remind you that so-and-so who's coming in for a sore throat is due for a PAP or whatever, so that you can actually do more than one thing in the visit. And she's also doing work as an improvement facilitator, improving our office work. So my panel number last week was that. And I can tell you this pretty much on a daily basis what it is. One of the neat things we did was just, we do this continuously, is looking at hemoglobin A1c targets. When we started this work, and that's not on here because it happened a long time ago, our target was 40%, which sucked. And again, once you measure, you don't know what you'll find. But it's okay if you suck, because then you know, and then you can go and change and improve it. And so very soon after we realized that, we started working with our team, and I'll get to some of the things we did. Again, could we be better? Absolutely. But we compare quite well, provincially and otherwise. And again, we have ways to know this is what's going on, and we work out how to help those individuals. Because not all of this, of course, is necessarily stuff that we're not doing, because you're dealing with people, individuals, who may not take their medication or show up or do their blood work, et cetera, et cetera. So again, it might not be your fault, but it is your problem. So panel lists, we have this group called the Health Quality Council of Alberta, doing great work for us. So even if you haven't got a panel set up, they can do a proxy panel for you. But if you do have a squeaky clean panel like we do, you can give them a validated panel list, and then they can give you some data. So what are the sorts of things that they might show you? So I brought a few things that might be interesting to you, plus as well, just to show you that...
Sorry, I may have missed it. Can you tell me what your definition of panel is?
So a panel would be the patients that are currently using you as their primary caregiver. And the best way to know that is to ask the patient. There are many ways of paneling. One way would be for a doctor to just go literally, scan a list and say yes, yes, no, 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 dead, moved, whatever. That's one way. But another way is to actually just proactively ask. Whenever people come into the office, you ask them the question, you tick a box, and then you record that. Yeah, so that would be your denominator. Yeah. So this just I didn't want you to think that I've only picked beautiful, healthy, worried well, cherry picked a patient roster. So what this is the age and the age distribution of my panel. And as you can see, it shows that my patients actually tend to be older than a panel of my peers. So I'm the blue, and then the yellow is me compared to a group of innovators in Alberta. So they're kind of high-performing physicians. And then the green would be Alberta as a whole. Also, what they have told me is that looking at complexity, my panel is typically more complex than compared to this innovator group and also the province. So another thing that you can do with when you know your panel is looking at screening and prevention. So this is an Alberta-made screening and prevention quality improvement project, which has been really exciting. And what this really looks at is the fact that family doctors do a fantastic job at screening offers, so not complete screening offers to patients when they come in for their annual checkup. But when patients come to see you for, again, their sore throat or UTI or whatever, you don't necessarily check and see if they need it. And that might mean that you are missing, up to a third and sometimes 50% of your screening opportunities in your patient population. And so that gap has to be addressed. So again, if you, this is also just a demonstration of where panel might be useful. So again, just, you might look different, but it gives you the idea. So if you do, 3 physicals a day, and, that's how many days you work in a week, and that's how many weeks you are in the clinic, very quickly you can see that the offers for physicals in your office does not actually even meet the demand of your patients. So small wonder you're not getting your screening done. So there's new ways to look at this. The one way is opportunistic screening. So again, that's the part where somebody sees you for an unrelated problem, and you also just quickly go through the chart and see, are there things that they maybe should be doing. That's again where the poet can help you with that, so that you don't have to do it. You can have reminders in your EMR to help you with that. But at the end of the day, I just think that it's always a good practice to just have up here. Because again, the more often you do it, you'll just automatically do it, and you don't rely necessarily on those other things that are not infallible. And then there's outreach. So again, because you have a team, you can do this. You and I are not going to be sitting after hours calling people to do this for them. That's why you have a team. And again, if you have your panel, and you can look, and you can look at who is due for a mammogram and has not had it, and you can call them up and send the rec over to the lab, and then they go do it, and then you say, great, that's outreach screening. So this is the menu of maneuvers that this ASAP program has. This was arrived at really to select screening maneuvers that are non-controversial, so that's why PSA is not on there. And this also represents about 75% of the leading causes of morbidity and mortality. And this is sort of a success story. So what this shows, so 600 physicians have taken part in this process in Alberta. And over a very short period of time, over a 4-month period of time, there was about a 17% improvement. So the gray would be baseline and green improvement. This is just a little bit looking at my screening. So, we started with baseline here, and that's when we started opportunistic screening. And as you can see, very definitely pick up. And then the next vertical line is where we started outreach screening, and again, improvement. This dotted line, is interesting because Lizzie discovered that there was a document labeling error in our system, and so that's why there's now, it looks like we've actually lost some ground. Again, it's cool if you find that happens. You just need to go find out why, and if you have an explanation for it, you change it. This just shows my clinic against Alberta and Canada, and again, we're ahead except for pap smears. Pap smears were the same as Alberta, but we somehow are not meeting the Canadian level, and I'm still scratching my head over this one. So again, and by the way, this is completed screening. This is not screening offers. And clearly there's a difference between those two. So this just shows my emergency room visits of my patients. And again, I'm the blue guy. And again, compared to the innovator group and the provincial group. And as you can see, again, now can we make a direct correlation between this and any specific thing that we do in our office? No, we're not that sophisticated, but something we're doing is working, because as you can see, it's way less than the average. So this is my patient's degree of attachment, and it shows that again, 20% of my patients only see me, and again, controlling, looking at me versus the provincial and the innovator group, it shows that that as a whole, my panel is more attached to me than the peers. And then this I want to show you, because again, everything isn't rosy. So what this shows is that my patients see specialists more than anybody else. Now, you look at that and you think, really? So that's not good. But now I know this, so then you ask a question. So, but what does specialist visit mean? So this could be people that go for a lung function test, and that lung function is interpreted by a respirologist. This could be people that go for cardiac screening that are high risk. Again, I don't know, but so all I'm saying is that it might be that some of that is appropriate. Specifically lung functions, every single COPD and asthma patient in my practice has been called in, reviewed, confirmed the diagnosis, has an action plan, has been, updated vaccines, blah, blah, blah. So maybe that's what drove some of that. At the end of the day, it doesn't matter. You shouldn't be afraid of things that don't necessarily look as good when you see it the first time. What it does, it prompts you to actually go look and find out what's going on. So again, my experience with PCNs, I started feeling like that guy. And now I'm, superhero, Mighty Mouse, super doc, all because of these guys that have helped me to do this. Last stretch here. There's a bigger picture here for all of us. And really, if I could, turn all of you into activists tonight, that would be fantastic. Primary care is the bedrock of the healthcare system transformation. And in the bigger picture, we're always hard done by, and I'm not talking about money to docs here. I'm talking about the system as a whole. People do not spend money in primary care. It always goes elsewhere. We need to change that because, by the way, for us to really have a robust primary healthcare system, we need more investment. And again, not to our own pockets, to the systems that support us to do the kinds of things I spoke about earlier today. There's no net new money coming. It's not going to happen. Don't even, think that way. Where is it going to come from? From within the system. Guess what? It's coming from acute care, specialty care. And of course, they're just going to hand it over without a fight and say, sure, have it. So we are really encouraging governments to have the courage that no other governments have had before, and that is to put money into primary care. Stop throwing good money after bad into acute and specialty care. This is hard, though, because politicians want results yesterday. Investment in primary care takes years to actually pay off. It's not a sexy topic. You're not running down the hallway with a beating heart and a cooler. So it's not something that's top of mind. So just a quote: we are positive that our ongoing discussions in this regard will be built on trust by patients and the state of the profession, but also trust of the profession by the profession of the state and patients to appreciate the limits and constraints under which professionals work. It's from Light. So when you fight this fight, you need to back it up with evidence. And so we've done some of this work already, looking at the types of things and benefits of working in a patient-centric medical home. And this was a literature summary of 73 articles. We looked at 70 of them peer-reviewed. And significant benefits were found for healthcare utilization, preventative care, quality of care, access to care, cost savings, and patient and provider satisfaction. So just looking back on our journey, there are a few lessons we learned. And one is that family docs are critical in this whole process transformation. You have to involve family docs at every step and involve them early. They need to be part of strategic planning and governance as well as at the practice level. And we also learned that that improvements that are related to areas of interest have better uptake. And you also want to break it up into simple steps with lots of support. Also, one part that is so underutilized is EMRs. They're often the most expensive part of your team, and most of us do not use it appropriately or to its fullest. So definitely need to look at that part. And then again, one thing is begin paneling, do it early, because if you don't do it, you're just going to go do some retrofitting and you're going to have to go do it at some stage. Also, don't reinvent the wheel. Beg, borrow, steal, plunder, whatever. Use what's out there. Don't think, though, that you can just, that it's not going shopping and I'll have this and that and the next thing. You want to actually be careful about why you pick certain things and what was at the root of their success. So I guess what I'm trying to say is that sometimes just going through the process of change is actually the part that is the most important part. The product is irrelevant because whatever product that you will come up with when you have the proper process would probably suit your needs. And in this regard, we want to learn from you, and we're very, very happy to return the favor. So we haven't figured it all out. It's not perfect, but it certainly is getting better. And we do feel like PCNs have played a big part of this. And I just want to acknowledge Michelle Hannay from Towards Optimized Practice, who played a significant part in putting together this presentation. And also just some websites that you can write down. There's lots of the materials and stuff available. Okay.